So good day, friends. This is Dr. Bob Hamilton, and you have tuned in today to the Hamilton Review, where kids and culture collide. Before we begin the show, I want to say simply thank you for tuning in. Number one, it means a lot to me. I know that all of you are working and moving and taking care of kids and grandkids and all the things that my families out there do. And you tuning into this program means a lot to me. And I want you to tune in. I want everyone to tune in because I'm trying to do my best to bring before you on a weekly basis phenomenally interesting and knowledgeable people. And today it is such a pleasure to welcome to the Hamilton Review, Dr. Santhosh Nadipuram. Dr. Nadipuram, welcome to the Hamilton Review.
Thank you so much, Dr. Hamilton.
So I want to tell everyone who this gentleman is. He is assistant professor of pediatrics in the infectious disease division at Gurren Children's, which is a division of Cedars-Sinai Hospital. He has a specialty, a subspecialty in toxoplasmosis, cell biology, which is over my head, I think. But anyway, that's what he does. But he also has done a lot of work in inflammatory pathways, which were very critical in terms of the COVID pandemic that we just got through, and also Kawasaki's disease. And he is incredibly knowledgeable about vaccines and basically everything you can think about in pediatric infectious disease. So, Dr. Nadipuram, thank you for being here.
Thank you so much. And I'll give a shout out to, of course, one of my many mentors at UCLA, Dr. James Cherry, who we all love and cherish, and without whom I wouldn't have this knowledge and drive that I have today.
And Dr. James Cherry is a friend of mine. He was one of our professors when I was doing my pediatric training over at UCLA. And I got to tell you, you were fortunate, Dr. Nadipuram, to be able to be under his tutelage, because he was truly a giant in the world of pediatric infectious disease. So you're fortunate. So
absolutely, still is.
Still is. He's still going. So listen, I like to have my guests say a little bit about themselves, where you're from, where you grew up, where you're born, maybe what kind of, everybody out there, Dr. Santhosh is not a pediatric infectious disease specialist. Have you noticed that?
I have definitely noticed that. Yeah.
Yeah, me too. And so you have found yourself in a very unique little niche in this world of medicine. And I think that everyone would like to hear your story on how you ended up where you're at today.
Thank you so much. Well, I'm the child of immigrants. My parents are from India, and they came over first to New York, and then I was born over there on the East Coast. We moved to Iowa, where I had most of my childhood. And then after undergraduate over in Omaha, Nebraska, I actually studied medical school at Rosalind Franklin University, which is the Chicago Medical School. Went down for residency to Miami Children's, which is now Nicklaus Children's. And that's where I really fell in love with infectious diseases. I think from medical school, I had a lovely mentor who told me that if you love working with children, you have to do pediatrics. There's no other option that you have. He was absolutely right. And it was the similar type of thing. It was very intuitive when I fell in love with bacteria and fungi and viruses and antibiotics and all the nerdiness that goes with it. So yeah, I was accepted into fellowship at University of California, Los Angeles, just up the street from where you are.
That's right.
Yeah, I was indeed very fortunate. I had an interview with Dr. Paul Krogstad, who was heading up the fellowship at that time, met all of the wonderful faculty, including Dr. Cherry. And I still remember to this day, he doesn't give out a lot of compliments, does Dr. Cherry? So at the end of the interview, before I left, he actually said the words, "You're going to love it here." And it's something which you're absolutely not supposed to say in an interview, because it's, you're supposed to leave things kind of open-ended. But I absolutely did. And I finished my training there. I did microbiology at UCLA from 2013 to 2018. And then I got here to Cedars-Sinai, recruited by our chair, Dr. Moshe Arditi, just 1 year before the pandemic started. So I was rearing to go by the
Yeah.
time COVID hit.
No, you were well placed when the COVID hit because everything. I think the entire nation began to traverse a crash course in virology. We all started
Yes.
talking about all of these viruses that were out there, and everyone kind of got sat down and began to become conversant, at least in COVID. So I'm
Mhm.
curious, going back a little bit, you said you fell in love with bacteria, fungi, and parasites and viruses. I find that to be an odd love affair. Not too many people I've never heard anyone actually say you actually fell in love with these little creatures because they cause all sorts of problems in this world.
Yeah, it's definitely a love-hate relationship. I think now we've known this for a very, very long time, but now we're becoming much more cognizant of the benefits that the microbiome has and how dependent we are on the microbiome around us, in us, to have actually a healthy life. And to find that balance between when the microbes are doing us good and when they're doing us ill and how to combat them, and sometimes how to address the host, when our immune system gets overzealous, and then sometimes to address the pathogen when we have to, show it its place and knock it down,
That's right.
was very interesting. But I always felt like, we're living in the microbes world rather than the other way around. So I had a very kind of strange view. I always felt like we have to find a way to get along. Otherwise, it's going to be bad news, probably for us.
That's a good way to put it. And I think that one of the things we do talk a lot about is the microbiome more and more, but in the GI tract in particular. And there are billions of bacteria that are resident there, and is something that I think as we get and it's a complicated milieu
Yes.
in the GI tract. One of the things I have to say, I'm teasing you a little bit about falling in love with bacteria because I actually began my work experience in the medical world in a pathology lab. And I was
Hmm.
actually in the bacteriology division of that pathology lab. I spent a lot of time swabbing blood agar plates for strep and all sorts of
Uh,
things like that. And I
okay.
learned a lot about bacteria, and I'm not so sure I developed a love for them, but I did develop a respect for them. And and I also found it to be extremely fascinating about this world that we don't see. And I'm kind of glad we don't see it because I think if we did actually see all the bugs that are floating around in the air and on all surfaces, we might get paranoid.
It would, exactly, especially the day and age we live in and everything that we've been through over the past 3 years. It is very hard right now to see the upside when you say the word bacteria or virus. But I'll put it a different way. You got to study one of the horrible pathogens that can really harm us, especially when it gets to the wrong place, like the bloodstream. But on the flip side, the vast majority of bacteria that are out there, if you were to count just the millions of species, just couldn't care less if we're around or they're just hanging out. And a better chunk of them are more commensal or helpful or symbiotic with us than anything else. So I have seen it a little bit of a different way, but definitely those of us who've studied the pathogens all of our lives, it does look like they're all out to get us, and it can scare us pretty darn fast if we start getting in the weeds.
Yeah, no kidding. Yeah, but they're lying in the weeds, by the way, talking about the
Yeah,
weeds.
they're the one. Yeah, exactly.
So I want to talk to you specifically about an article. It was actually the lead article in the perspective section of the New England Journal of Medicine. This came out a month ago, friends, in the February 8th edition, 2024. The title of the article is The Risks of Normalizing Parental Vaccine Hesitancy. And basically, the essence of this article is that we are, as pediatricians, we are dealing, I would say, with an increased percentage albeit not a big percentage, but there is definitely out there in the ether, I guess, the sense that people are more wary of vaccines. And it is something that we deal with on a literally a day-by-day basis now. And I think that this is something that concerns me, because I do think that vaccines are good. They have radically changed our world from smallpox way back when. And by the way, we all know, maybe our listeners don't know, but certainly Dr. Nadipuram, you know that there was a great controversy about the smallpox vaccine. I mean, when the method of immunization way back when, in the days,
Oh yeah.
in the
Um,
old days. Tell us about that.
oh yeah, you're talking about all the way back in the days of George Washington. So yeah, from the birth of the nation that we now call the United States, George Washington had recognized the usefulness of variolation, which was the first smallpox vaccine that Dr. Jenner had come up with. And this was taking a pin with the smallpox on it, and actually it was a little scary to see. You had to scratch it into the skin. So it was not an injection. And folks did not understand the protection that it afforded against severe disease, disfiguration, and death. And at the time, I will say, from our perspective now in the modern times, it was not a terribly safe vaccine, but for what it was, it greatly reduced, the risk from the actual disease. But yes, there was, I can't remember, it was 1800 and something, but there was a vaccine riot. And people were rioting against what General Washington had done for the Continental Army, which was to mandate smallpox vaccination or variolation.
Yeah.
And people were saying, oh, you're poisoning us and you're doing all this thing. There was another protest of that kind that's famously up north in Canada, not too long afterwards. So the misunderstanding, the lack of comprehension, and the falsehoods that have been propagated about vaccines are actually much older than we think.
That's right. So I think is one of the things that people maybe they don't understand when they see their child quote injected with something. It does unnerve them, and I can understand that. I'm a father, and I can understand how that kind of is uncomfortable. But it isn't the benefits of vaccines. I have seen it in my own career, and I haven't been. I've been in practice for a while, but it isn't like I think about HIV and the benefit of that vaccine, in children. I mean, the number of kids who have HIV meningitis these days is almost zero. And it is
Yes.
such an amazing development. Even chickenpox, to be honest with you, chickenpox is gone. I mean, we don't have chickenpox anymore.
Yeah, and much more importantly, in the generations that are coming up now, because thankfully, chickenpox wasn't commonly fatal or very, very dangerous. You certainly could get superimposed bacterial infection and have horrible skin disease or pneumonia with it. But secondarily, these
That's right.
children don't have to live with the chickenpox virus in their body, which is where it lives once you have it, once you acquire it. Because they were vaccinated instead, they don't have the probability for that varicella zoster virus to reactivate and cause something that a lot of people really do fear later on in life, which is shingles.
Yep.
And so, we really reduce that rate. And likewise, reactivation of VZV in scary places like over your face and over your brain, you take that risk away. I was in residency when the first really good rotavirus vaccine came around. And this was Rotatech, commercial name. And it was so amazing. And probably, Dr. Hamilton, you remember something like this with Hib, as you were saying, with the HIB vaccine. There was one year in 2007, where you would have your routine kids coming in the wintertime for bronchiolitis, which is wheezing, and then diarrheal illnesses from rotavirus.
That's right.
And in a young child, they just have diarrhea for days and days, and there's nothing to do. You just have to give them fluid hydration until it just stops. And the vaccination program started up with, introduction into the childhood vaccines, the following, I think that summer. And that population, Dr. Hamilton, that we were like we were putting cribs in the corners of the hallways because we would have so much overflowing of diarrheal illnesses. They just up and disappeared.
Yeah.
Those patients just did not show up, and those days of hospitalizations were gone, and the kids, the occasional child who would get severe illness, those were gone. And it was such a relief on the hospital system, on the doctors, and on the parents.
That's right. Well, I mean, we're just backing up a little bit, just for those who are listening. Rotavirus is a virus which causes GI problems, and namely wicked, terrible diarrhea. And in the U.S., in the first world, we can put these kids in the hospital. We can hydrate them with IV fluids and also oral fluids, and essentially rescue them. In the third world, where they don't have the resources we have, a lot of these kids go to heaven. I mean, they really do. They're gone. And especially places like Bangladesh and other places like that, where they really do have, that was kind of where the rotavirus was particularly studied, as you are well aware. And the amount of infant mortality which has been eliminated by this one vaccine is, I mean, millions. I would say millions and millions of children have been saved. Their lives have been saved. So we've seen great advancement. And I would just want to say one thing parenthetically. People ask me, they go, Bob, there's so many more vaccines today than there were when you were a kid. And I look at them and I say, you know what? I wish there were more. I wish there were like 20 or 30 more. I wouldn't mind having a vaccine against dengue or against Zika, about Ebola, or a better vaccine against COVID. I mean, all these vaccines that we are now giving. I want more, and I know that sounds crazy to people, but that would be a blessing.
Absolutely. There is that false association that, as you give more vaccines, there's higher risk. That's not at all true. Giving a vaccine is akin to, the same kind of exposure that we have on a daily basis to all of these viruses and bacteria that are, like I said, around us all the time, but just introduced to our immune system in a non-violent fashion, such that our immune system can gain that memory and store it away, and then attack when the real disease hits. But we are bombarded by no less, antigens, so to speak, so viruses and bacteria principally, around us all the time anyway. So just because it comes in a package like a vaccine, it doesn't mean that you're giving anything excess to what we're being exposed to regularly. We are evolved to handle this. It's really just that you lower the risk of complications from that disease by a massive factor when it's introduced in an attenuated form or in a component form like a vaccine, rather than having to stare down the disease itself and hoping that you win.
So going back to this article and the idea that vaccines are hesitancy, they call it vaccine hesitancy. I do think it's important that we let people know that the vast majority of our patients get their children vaccinated. So even though there might be more controversy, in the end, people are getting their children vaccinated. And I think it's important that we understand, that people understand that, because there is a certain amount of social, norm influence and how it influences parents. It does influence parents. We are subject to those who are around us and the thoughts and the ideas of the people we associate with. And if the idea, in my opinion, and I'll let you share this, your thoughts, if we allow this idea of the normalization of vaccine hesitancy, if we allow that seed to grow, it produces, is first of all, is not true because there are maybe people think twice, they ask questions. That doesn't mean they're anti-vaxxers by a long shot, long
Right.
shot. But I'm worried about that phenomenon. Your thoughts?
Yes, I agree. We are social creatures. First and foremost, we do the things that are, quote, like acceptable to the people around us. I'd like to say that we all try to do things for, the right reason, that kind of nebulous right reason that we think about. But by and large, we also do care a lot about the opinions and the views of the people around us, especially those who we respect. If we have a perception, if we, and in this case, you're absolutely right, a false perception that those around us, those people in our community and our friends and our colleagues are not doing something, in this case, if they believe that they're not vaccinating, and then if there's any loss of respect, loss of faith, as there has been in the last few years, some of it engineered against science and against doctors who really, really care, then that's all it really takes for it to go from questioning whether to do vaccination to hesitancy, and then these kind of steps to refusal. However, with everything that I'm saying, you're absolutely correct. Across the board, when we look at vaccination, we have 90% plus of the children who are supposed to be receiving their vaccines on time are receiving those vaccines. And the hesitancy that we think about are actually in kind of specific and regional areas. And they do have to do with beliefs and thoughts within really specific communities, so to speak.
Yeah, and the 90% is actually pretty darn good.
Oh, yeah.
But I do think that there's one thing, and I will tell you that I have patients who tell me this, the phenomenon of herd immunity. Herd immunity simply means, well, I'll tell you what, I'll let you define herd immunity,
Sure.
Dr. Santhosh.
Sure.
Okay.
Yeah. So herd immunity is the idea that if there are enough people in a group that have gained immunity against a particular disease, so it doesn't have to be vaccines. It can be natural, but in this case, we're talking about vaccine herd immunity. Then if there is a person in that herd, so to speak, in that group that cannot get vaccinated or did not mount a vaccine response, maybe they are immune compromised, then they sit in the middle. You can imagine them surrounded by the group of people. And so if that disease, almost like you're throwing a ping pong ball at that group of people and trying to hit the person in the center, if enough of those people on the outside are shielded or are immune, then those folks in the middle of that herd or that group, maybe I shouldn't be calling human beings herd, but
No,
uh,
that is called herd immunity. So you can, that's a,
you totally can. So the people, and oftentimes it is children who maybe are ineligible for a vaccine or they're immune compromised, that in the middle of that group in that center are protected by all those people in the herd surrounding them. And that little ping pong ball of a disease has a much harder time zigzagging through and hitting that person in the center if they're surrounded by the herd.
that's right. Now, the magic number for herd immunity is what?
It's about 95%. With some vaccines, it's a little higher, a little lower, but that's the bar that we want to hit is vaccine coverage of 95%. And in a generic sense, in terms of immunity, around that number is what we want to see.
So I just want people to hear that number very clear. 95%. That's a pretty big number. That means that 95% of the population needs to be vaccinated against a particular organism or
Mhm.
pathogen
Yeah.
to allow there to be safe or herd immunity. That means if that's 1 in 20, okay, that you're the 1 in 20. So you got to make sure that all 19 of the other people around you are vaccinated. Otherwise, your child is going to be higher and more subject to the that particular infection, whatever it may be. So
Right.
that's a pretty high level. And so there are people out there, and those listening, you know what I'm talking about. They're hitchhiking. They're basically surfing the wave of herd immunity, saying, well, everyone else is vaccinated, so I don't have to get my child vaccinated. I don't
Yeah.
think that's a good way of thinking about things.
Yeah, and if you want to be really harsh towards a parent or something like that, and I will say in my younger days when I was quite hot-headed about these topics, which is, by the way, not at all a good way to get people to take up vaccination and explain that that strategy just doesn't work. But in those days, I would use words like irresponsible, that just like you're saying, oh, they're taking advantage of those around them to protect them. But nowadays, I'm much more aware that, aside from, misinformation and unfounded fears and things like this, there is a basic psychological thing, which is very true of all of us humans when you're trying to talk about prevention rather than treatment. So preventing something you can't see in terms of, oh, that disease is not active in our community. In fact, in something like rubella, where we try to prevent, the viral infection from causing an infection in babies of pregnant moms, which is why we vaccinate, everybody. We haven't seen it in 20 plus years. The Our ability as human beings to convince each other to say that, like, oh, but we have to keep doing the thing that's preventing the disease from coming back or blooming. That's a much more monumental task than pointing at something actively as a problem going on in front of you that's tangible and that you're trying to you're trying to reduce the incidence of something that's like in your face and going. So the joke that they always say, if we were all of us were back home, in villages or some things like that, that it's much easier to convince someone to, oh, there's the tiger right there. So let's back away slowly versus, oh, you know what? We have to build all of our houses now because the tigers are coming, but they're not here yet.
So I call that perceived threat. And if you perceive a threat, then you do something about it. And I will tell you a little story that I have people in my office who have come in and said, we don't believe in vaccines. We don't want vaccines. I said, okay, that's fine. And then there was a time when they were sending these letters that had, what was the name, the pertussis, what was it, pertussis, what was the name of the organism that they were sending these letters out, and they were finding, I can't remember it a couple of years ago, forgive me, I can't remember.
Yeah, if you're talking a few years back, the one of the big things that hit California was whooping cough.
Yeah,
If you're thinking of pertussis, and we had a drop off in vaccination rates. This was pre-pandemic. This was, maybe 2010, 2011, and we had enough of a drop off that we saw a significant rise in infant deaths specifically.
that's right.
Because infants, we don't give the pertussis vaccine until a little bit later on, a couple of months of life. But the vulnerable children are the ones who are very young, less than 1 month old, and who can really die from this. So we really do depend on the herd immunity of the parents and the other siblings in the house, and household members to be well vaccinated, as well as doing other practices to keep, respiratory illnesses at a minimum around that newborn baby.
That's right. And so when people perceive threat, when they see the disease, the community, they immediately want it. And even
Oh,
people
yeah.
people who were saying, "Oh, I don't believe in vaccines," they suddenly became vaccine believers. It was the craziest thing. I would have people call me and say, "I want that vaccine." I go, "Okay,
Yeah,
let's get it." And
let's do
so
it.
so perceived threat is one of those things. If you don't perceive threat, that I don't think you're motivated to do things. But I also think that, as I said before, the social norms of the community that you're in definitely dictate a lot of our actions as well. Interesting too, there's a new RSV vaccine or RSV immune globulin, which has been recently put out there. We call it Beyfortus, or the other name is called nirsevimab. And
Yes, yeah,
the
and
interesting
a antibody against the RSV
that's right,
RSV virus. Yeah.
virus.
hmm
So I know that you have you're on the forefront of that. Tell us a little bit about that, and also some of the data you were that you had mentioned to me before we got going here.
Oh, absolutely. So, nirsevimab is, just a beautiful effort that's taken a very long time. This was something that actually it highlights how seriously we take actually vaccine safety as well as efficacy. RSV vaccines were conceived in the 1960s, and the original ones, unfortunately, did not prevent RSV. In fact, they created a complication, and these were whole cell formalin killed viruses. And they actually created the wrong type of reaction, and actually in some cases worsened RSV bronchiolitis. So for the longest time, we recognized that immediately, and that was pulled. And that's true of a lot of vaccines, and we hold them to a very high safety standard in the United States and in the EU, as well as by the WHO. So for the longest time, everyone was just very concerned and afraid, even in the pharmaceutical and the medical science community, to just don't touch RSV, And we had this antibody called palivizumab or Synagis, which would be given to at-risk premature babies to help them protect them. But we didn't have anything that we could give to all babies to prevent RSV. But uh, enough folks got together, really smart, wonderful people, and said, "Oh, you know what? Let's not actually introduce the antigen. Let's just give them an antibody against it." And they engineered nirsevimab, this antibody, and it was first really trialed large scale. An equivalent population to us was in the European Union and the United Kingdom. And then this winter, so winter of 2023, it came over to us, and we saw drops in rates of hospitalization of something like 80 to 90%, just massive. And a big part of this was that people wanted it. They asked for it. Now, there was an interesting thing that happened was that the expectation of how many people would accept nirsevimab on their vaccine schedule was missed. And in fact, there was a production shortfall.
That's right.
You probably suffered through
No,
that.
you're absolutely right. We were like, where's the product? We needed the
Where's
product.
our vaccine?
Yeah,
And thankfully, we were able to do a little bit of catch up and deliver as much as we could. And even when we didn't meet production, I say we, the United States didn't meet production goals and targets. There was still enough of this coverage that our early estimates, and this came out in from the CDC in March 7th of 2024, that the effectiveness was 90% against RSV-associated hospitalization for infants who are entering their first RSV season. So very young babies who are the high-risk kids.
that's right. That's
And
right.
yeah, I couldn't be happier. They would catch RSV, but they wouldn't get, deathly ill from it. And the same that we saw with rotavirus, 12 years ago, we now saw this beautiful fall off in the cases of really sick kids with respiratory illnesses. There may be a correlate later on in life because we know that severe RSV infection is correlated with the development of asthma in a lot of kids later on. I kind of have my fingers crossed that as these kids age, having received nirsevimab in their youth, in their first year of life, that maybe we'll see drop-offs of things like asthma too, which would be lovely.
Which would be really, really lovely.
Yeah, yeah.
I think the fact that people really wanted this particular immune globulin, and the demand was definitely there. again, is a phenomenon of what I call perceived threat. They heard about RSV. They heard stories about their friends whose kids went into the intensive care unit or whatever, had to be in the hospital, and they thought, we don't want that. And there's enough RSV out there in this community that people know about it, and so
Yeah,
their perceived threat was very real. Well, listen. I'm watching our time, and I've made a promise to you to get you out of here so you can go back to your job over there at Cedars. Before we do, I just want you to, can you say a little bit about what's happening at Guerin Children's? Because I think that there's a lot of excitement at Guerin Children's at Cedars about what's happening. And can you just say a word about from your perspective?
Oh, you're so kind. Yeah. So the pediatrics team over here really has undergone a bit of an explosion in the last few years, and it was right during the pandemic. We got a very generous gift from the Guerin family, which allowed us to open a brand new the Guerin Children's wing over here, which was a 27-bed hospital, including the type of rooms that you need to shelter kids when they come in with respiratory illnesses, as well as epilepsy monitoring unit. We've expanded the intensive care unit to include our cardiac care unit and children who have congenital heart disease. And we've always been here at Cedars-Sinai one of the largest centers for mother, baby, and infant care in California and I think in the country. And that is still going very, very strong. And I'm so proud of all of our departments, our nursery, our NICU, and we've expanded our subspecialty repertoire and surgical repertoire. And so, yeah, I'm very honored to be working with just the most amazing group of pediatricians, pediatric surgeons, radiologists who joined us a little while back, and then of course all of the ancillary care team like physical therapy, occupational therapy, respiratory therapists who are tremendous, backed by a really powerful research program that's here. So my mentor and chair, Dr. Moshe Arditi, who heads up the Infectious and Immunological Diseases Research Center, IIDRC. I always have to get that right. And along with several professors, Dr. Shuang Chen, Dr. Kenichi Shimada, Timothy Carruthers, and Magali Rivas Noval, among others. And then a lot of other wonderful researchers across the divisions here at Cedars-Sinai. So we have that beautiful blend of community care and academic and research work. I was honored to participate as a site in one of the inflammatory and immunologic research group that was headed out by one of our partners out in Nebraska that studied this phenomenon of MIS-C, the multi-system inflammatory syndrome associated with COVID in children during the midst of the pandemic. So
Yeah.
yeah, that's my plug.
That's a good plug. Well, I think that Guerin, thanks to the Guerin family, have really kind of accelerated a beautiful thing over there, and you're nicely placed, I have to say, Dr. Nadipuram. You really have landed well in that place, and I'm excited for Cedars. I also understand that they're going to begin a residency program again. They had left
We
that.
had one. Yeah.
So it's happening again. I think in 24, 25, you have a new group of I think 8 coming in, and I don't know
Oh yeah,
how did
absolutely
you
right.
guys
Yeah.
did you guys match? How did you guys match?
We did. We matched beautifully. We're so excited. We filled out all 8 applicant seats that we had. And you're absolutely right. This is not a fresh start for the residency. This is a rebooting of
It's
the
a reboot.
residency.
Yes.
That we had a wonderful residency program and then we're still in partnership with University of California, Los Angeles. Their students come here and rotate as well as their residents, and we're along with our residents. We do want to continue the community partnership as well as our good relationship with all of the children's hospitals and centers in Los Angeles. Dr. Hamilton, as you know, we do so much more good when we work together, and when we're able to communicate with each other, share knowledge, share treatment. I think we all have our specialties that we're really, really exceptional at. And then all around, the children's programs in Los Angeles are, of course, second to none, in my opinion. And so I feel really lucky to be here. And if we continue our collaborative atmosphere here, including things like vaccine education and encouragement, and we do it in a good community-based manner, I think we'll keep getting better and better, even through horrible things like the pandemic.
That's right. You're going to win. That's basically it. And by the way, from my perspective as a general pediatrician in the community, I can tell we are really, really happy about what's going on over there at Cedars. It really does enlarge our ability to care for our patients. So thank you for the work that you do.
Thank you.
So friends, we're finishing up this episode of the Hamilton Review. It's been a great pleasure to have Santhosh Nadipuram. He's an assistant professor of pediatrics in the infectious disease division. Disease division. That's a difficult to say. At Gurren Children's Wing at Cedars-Sinai. So such a pleasure to talk to you today, and I wish you the very best.
It's an honor, Dr. Hamilton, and thank you for everything you do.
You're welcome. And friends, thank you for listening. Until next time, be well. Bye-bye.
You have been listening to the Hamilton Review, where kids and culture collide. Thank you for allowing us to be a part of your day. Tune in again next week on Apple Podcast. Rate and comment and tell a friend.